Yeah, perfect. Thanks.
Thanks. So it's also an honor to introduce Vittoria Colizza. Thanks very much for coming to speak with us about COVID-19 testing protocols in schools.
Thank you very much. Thanks a lot, and thanks a lot for this invitation. I'm really quite happy to be in presence today, presenting our work. And this is going to be very likely quite a break with respect to what we listened so far, because the situation in France about regular testing has been very different. This never really took place in terms of recommendation or policies implemented. And so the story, it's a little bit about a lot of modeling support that we provided that were largely supported by the Ministry of Health, but then were never implemented in schools. Authorities' number one objective has been since after the first lockdown to have schools open as much as possible. And this was actually an objective that was quite successfully reached, because if you look at the statistics across Europe, France is among the first, it's the second country that kept schools mostly open. After full closure during the first lockdown, we're talking about the spring of 2020, schools were reopened. They were only closed let's say with an excuse of Easter holidays, so to extend these holidays during the third lockdown, and that was spring 2021. But with these two exceptions, they've been completely open since. And let's say that going back at the start, per week, because this was a weekly screening, and also about adherence, which we know that is a very important so a very important element for the impact. And here we have an adherence that is ranging between 60 to 80%, which is not bad, especially, and we're considering here, I'm showing only data for primary school, also data for pre-primary school were available, and especially considering that our adherence instead secondary school in the pilot screening was really very low, about 10%. So on the left, there are the prevalence reported for all the schools in 2 different departments, and those are the ones highlighted in yellow, for which we have a larger amount of data. So we included them in the study, but then we extended also to the full data set without big changes. So we used the maximum likelihood inference of the transmission per contact in order to understand what is the transmissibility on each of these contacts that we have in the network within the school. This is so an approach that we already had developed to study the pilot screening, in which we estimate the transmissibility per contact, but also accounting for importation from the community, which are self-consistently estimated as well. And what we end up having is, so here I'm reporting the estimated reproductive number specific to the school, to the primary school. And so we found this weekly screening as for that time period to be slightly above 1.4, and anyway below the RT, which I didn't put in this plot, but below the RT that was estimated, that could be estimated from community surveillance in the same age class. Then what we looked at was to estimate what would have been the within school R for the other 2 protocols, which are reactive in nature. One is the reactive screening, so the one underlined in yellow, which was the protocol in the remaining schools of the departments, which was the national protocol at that time, and then the reactive closure, which was instead a previous protocol mainly used throughout the pandemic, throughout the first year and a half of the pandemic. And we found that there was these values were larger. So in terms of reduction compared to the reactive screening that was the protocol in place nationally, we found that reactive closure was actually a little better. So the first protocol that was implemented was a little better than the second one, with a reduction of about 3% point estimate, but of course large fluctuation. And then a weekly screening was instead largely better than the national protocol that was implemented. And if you, through the model, of course, you can also compute the expected number of cases, compare it to the observations. And what you find is that these, in the time period under study, this was expected to have reduced by 40% the number of cases in the schools that participated to the experimental protocol of weekly screening, compared instead to the reactive protocol, reactive screening in place. Then, of course, you can extend this. This was specific to a very specific period, a very specific situation. So through the model, of course, you can extend it in different conditions, which correspond to different condition of frequency, different condition of adherence, different conditions, for example, of importation of R in the community. And what you find, and especially we were interesting because we wanted to underline the value of regularly screening a student population compared to the protocols that were implemented so far. And what we found is that reactive closure under let's say the plot on the right, reactive closure was was predicted to reduce cases of about 15% under the conditions that I'm showing here, which were, let's say, a lower R, a lower introduction compared to the Delta wave. And anyway, the advantage was always advantageous compared to the reactive screening of the class. And notably, this was also true when full adherence to reactive screening was considered, which of course was not the case. And also when reactive screening was followed by control screening, for example, 3 days after, meaning that you find a case, you test the entire class at day 1, and then you retest your class at day 4. now these days, of course, change a little bit based on logistics. Clearly, what we found was confirming what was already found at that moment. And these were results that we studied communicated by, it was the end of 2020, so quite early, even before the availability of LFT tests in France. Clearly, as expected, the impact, the preventive advantage of using regular screening increases with adherence, increases with frequency, that is from bottom to top over here. And then interestingly, you can find that, of course, there are some compensation effects. So in the cases in which you have little adherence, you can compensate with increasing frequency, and vice versa. If you have a very good adherence, you can lower a little bit the frequency. Now, of course, you wanted to compare that also with the cost. The first cost we looked at was student days lost. And so here on the y-axis, we have still the percentage of case reduction. These relative variations are compared to simple symptomatic testing in order to be able to compare different protocols over here. And they're obtained under different conditions, either of importation or also of R. And what you find is that reactive closure is extended, let's say, on an horizontal axis, because of course it always very demanding in terms of student days lost, because it requires people to stay at home and it's not specific enough. The dark blue, we tested it as it's a reactive closure of classes of the same grade, because based on empirical data, we saw that there was more mixing, of course, between classes of the same grade than between classes of different grades. And this is simply because of age-specific assortativity of contacts in the school. And if we look at regular screening, we see instead that these data points are mostly aligned on a vertical axis, where of course the higher the adherence and the better is the result in terms of case reduction. And this happens always for a rather limited increase in student days lost. The advantage there is that of course you find more cases, so in principle you put more people in isolation, but at the same time, given that you're breaking chains of transmission, you're preventing further cases along the way. And this was a concept that was extremely difficult to communicate. Reactive screening, on the other hand, is very close to zero, in the sense that it has a very limited impact in case reduction. At the same time, on the other hand, it has a very limited impact also in student days lost, because you see little. You see only when there is a case detected for any reason, either because of symptoms or because somebody else tested positive in their family, and so the full family has been tested. And again, this was probably one of the reasons why it was helpful in order to keep the objective number one of not closing schools. We looked at different conditions, different circulating variants, introductions, vaccination coverage conditions, and also control screening in terms of reactive screening followed by different controls. And then the last thing that we looked at, because one of course, let's say after communicating these results, something else came up. And one of the biggest, I think also listening to you today, one of the biggest differences is that in France, you could access testing for free in every pharmacy since the beginning of the epidemic. And for that reason, the use of self-test was probably never really pushed or never really adopted largely and widely in the population, because in that case, you would need to purchase them at the pharmacy. Now, cost is really limited. It's about €6 for a pack of 10 tests, but still is compared to, of course, paying nothing if you go to the pharmacy. On the other hand, likely you're not going to the pharmacy every week to get tested, or every twice a week to get tested, because it becomes, of course, cumbersome. So the problem arrived during the Omicron wave in January, where clearly authorities decided we had to face these large incidence conditions. The points correspond to data points on the top corresponds to the community surveillance for children in France in January, February 2022. And in that case, facing this new wave, authorities decided to change, always keep the reactive protocol, but incrementing the number of control tests. So at that time, this strengthened reactive protocol was supposed 3 controls within a week, task controls within a week from the identification of a case. And of course, a large fraction of the population was testing positive. So what happened is that because of logistics, you had long queues at the pharmacy for students getting tested. Then after first week of chaotic organization, authorities decided to give documents issued by the schools that could allow to get a free self-test still at the pharmacies. Of course, the stocks were not sufficient to face the increase of demand. And so there was a problem once again of testing and demands. And so we wanted to look at the other costs, so the actual cost of testing, because one of the let's say responses that we got throughout this time was yes, but we're not putting a weekly testing or anyway a regular testing at school because this would require too much testing, given that we have to do it overall in all schools. So we cannot allow different schools to adopt different protocols, and that's the égalité à la française. And so what happened is that we wanted to look at effectively under these incidence condition, whether the reactive testing with 3 control tests was still advantageous compared to something that was performed regularly. And what you can see, I'm just keeping, for example, the incidence curves on the top. You can see over here that when you get to the peak of your incidence, of course, the demand in reactive testing is very high and approaches even surpasses the demand of weekly testing, which on the other hand decreases right after the peak because of the fact that you find cases, so they are not in class, so you're not testing them anymore. You already found them. We extended them to look at different incidence conditions, and we always found, so once again, that the peak reduction of reactive testing, which are the green, would be always very limited for different incidence condition, and instead one would have an advantage for a comparable use of resources in terms of tests per student week by using at least weekly testing. And based on that, what we're planning to do is something that was similar to what Stephanie was presenting before, trying to identify different ranges of incidence for which introducing different testing. But of course, this becomes harder and harder as the communication about the pandemic goes further. So I'd just like to thank here, I need to thank a lot of collaborators who participated. And in particular, I think I need to thank the Académie de Lyon, which was the one who put in place these protocols and allowed us to work on the data. Thank you very much.
Questions, a few minutes. Yes, sir.
Thank you very much. That was very cool. I'm really interested to see what was going on in France too. I wonder, so the reactive screening generally didn't do a lot, but I wonder if the general population of adults were doing more testing, would reactive screening work better then, because you've spot more incidence cases anyway because you trace them.
Yeah, so it is true, and it's very hard, I think, to let's say to disentangle the two things. So for example, during the Omicron wave, indeed, let's say the underdetection, for example, in children was probably lower because a lot of people, a lot of adults were testing, and so then extending the test to the family, we're discovering cases also in the children. In general, I think that what happened was really that from a approach point of view, the paradigm of regularly testing was never really communicated properly. And so it was more about a recommendation, for example, testing before joining your families, for example, during Christmas time, but very punctual, very specific. It was maybe you want to test before going to a party, but I'm not sure that this is happening. And also the name that was given to asymptomatic testing, they are called test de confort, which the translation is, it's like testing for your self comfort, your self-assurance, something, but it's not, again, it's not so much about control, and it's not so much, of course, about public health point of view. So I think that also that perspective in the way it was communicated had strong limitation for people uptake. Sorry.
Victoria, when people went to the pharmacy to get a test, was that a lateral flow test that was administered locally, so that the pharmacy took a note of negative, positive, or?
Yeah, so in France you could still, and even up to now, you could still do both. You decide which pharmacy to go to. They offer either one or the other, or sometimes they offer both. And if it is an LFD test, you would do that on the spot, and all tests are put together in a centralized database. So the person receives a text on the phone like 15 to 20 minutes after about their status, and then follow up, let's say, instructions in case it is positive.
Did you also say that a pack of 10 lateral flow tests to go home was €6, so basically 60 pence per test?
Yes, it's very cheap compared to other countries. I know. I have guests who were coming from abroad who basically filled their luggage to then fly back home. I know it's very cheap. And again, it's always a matter of perspective. It's very cheap, but still costly compared to a test for free, which you would get at the pharmacy. On the other hand, preventing somehow the wide use of tests at home means that you act on habits, and you're not able somehow to create those habits of testing at home. Even for schools, a big deal was let's say, to ask testing. And at the end, authorities decided to have the testing at the school instead of having the test at home, because parents were largely complaining about doing that by themselves, and teachers as well. So thank you.
Getting the slides pulled up for the last part of this session.